My pleasure, everyone, to formally introduce Laura Enyedi, who is a professor of ophthalmology at Duke University and specializes in pediatric ophthalmology. And she also has a secondary appointment in pediatrics. And Laura, I just learned from your CV that you were born in Rochester, New York.
I certainly was.
Amazing connection there. She got her BS in psychology at Duke and then her MD with distinction at North Carolina. She went on to residency at Duke and then a 2-year pediatric ophthalmology and strabismus fellowship as Duke as well, and then joined the faculty in 1999. She's had more than 100 publications, 6 book chapters, and even edited 1 book. She's received a number of professional awards, some of which include Women in Ophthalmology Mentorship Award, Women in Ophthalmology Special Achievement Award, the American Academy of Ophthalmology Achievement Award, the PDIG Performance and Quality Award, the APOS Honor Award, and the Golden Globe Award for Resident Education. She's been very active in several organizations, including PDIG, APOS, the Women in Ophthalmology, and the AAO. She's been a clinical spokesman for the AAO, an AAO1 network editor for pediatric ophthalmology and strabismus, as well as an AAO ophthalmology advocacy leader. She also participates in AAO Subspecialty Day Committee planning. Currently, as a member of Women in Ophthalmology, she's on their board of directors and also the membership chair. Currently, her areas of research interest include innovative educational modalities for ophthalmology residents and fellows, sexual harassment in ophthalmology. She's the Duke Principal Investigator for Pediatric Eye Disease Investigator Group. She's interested in pain control and pediatric strabismus surgery, amblyopia treatment, and intermittent exotropia treatment. It's certainly our pleasure today to welcome Laura as the Flom Eye Institute Distinguished Visiting Professor. She'll be lecturing on pediatric eye disorders with skin findings and the other way around, and perilous pediatric problems, diagnoses you don't want to miss. Laura, it's a pleasure to welcome you.
Thank you so much. I'm going to work on sharing my screen. Okay, I think we're good. Thank you so much for that really nice introduction. I really appreciate it. I want to thank Dr. DiLoretto and Dr. Garinger for inviting me, and I'm so disappointed I couldn't come see you all in person to see your department and interact with all of you, especially your residents. I'm a diehard Blue Devil, and I'm a Southerner, having spent my entire career at Duke and almost my entire life in North Carolina. As mentioned, I was born in Rochester, and I feel very connected to the University of Rochester. Both of my parents graduated from the University of Rochester, and I was born at the Genesee Hospital in Rochester. The Genesee Hospital was founded in 1887 as the Rochester Homeopathic Hospital, and it had 385 beds prior to closing in May 2001. The hospital was demolished, and it was replaced with this building that houses now MVP Insurance. And I hope to come to Rochester to see all that. And ironically, in 2001, just when the hospital was closing that I was born in, Dr. Garinger joined us at Duke as a fellow when I was just a newbie attending. And we can flash forward 20 years now, and we get another Matt from Rochester joining us. And we're just delighted that Dr. Haney matched with us, and though we can't wait to welcome him to Duke. I'm a pediatric ophthalmologist, so of course I have no relevant financial disclosures. I will be discussing off-label use of drugs. This is the Blue Ridge Parkway near Asheville in North Carolina, and I just wanted to talk to you about the journey we'll be taking today, connecting the skin and eyes with lots of sightseeing along the way. We're going to talk about some common and rare neurocutaneous disorders, including vascular disorders. This should be a good review for the residents of all the phacomatoses as they get ready for their OCAPs. We're going to look at some pigmentary disorders, including those with too little pigment and those with too much pigment. And then we're going to talk about some really common disorders that have in common lid margin disease. Let's start with neurofibromatosis 1, which is one of the most common neurocutaneous disorders with eye findings. It's caused by mutations in the NF1 gene, which regulates the production of neurofibronin, which is thought to function as a tumor suppressor. In about 50% of individuals with NF1, the disorder results from a spontaneous mutation of the gene that occurs for unknown reasons. And in the other half, it's inherited as an autosomal dominant trait. There's sort of classic skin findings that we probably are all familiar with, including cafe au lait spots, inguinal and axial freckling, and neurofibromas. Oftentimes, changes in skin pigmentation are evident by age 1, and they tend to increase in size and number over time. Lish nodules are one of the most common ocular findings in NF1, and they're present in 40% of 5-year-olds and about 95% of adults with NF1. They're a useful clinical marker, but really have no effect on ocular function. Optic gliomas occur in 10 to 20% of NF1 patients and usually develop before age 7. These are benign, low-grade pilocytic astrocytomas that may affect the optic nerve, chiasm tract, or hypothalamus. In this example, there are changes to the optic nerve on fundus exam, but this is usually not the case, and gliomas can be difficult to diagnose without MRI imaging. They can cause visual symptoms, but subtle visual changes can be difficult or impossible to detect in children. Patients may also develop plexiform neurofibromas that give the characteristic S-shaped deformity, and this is a little girl that I've followed for most of my career who's very unfortunate. She's had this terrible orbital plexiform neurofibroma that's grown over time. It's been resected and debulked multiple times. Surgery is difficult because these tend to bleed and the lesions are infiltrated, so it's difficult to remove the mass without damaging normal structures, such as the lacrimal gland and extraocular muscles. Fortunately, there's a new drug treatment that was approved by the FDA just in April of 2020 to treat pediatric patients age 2 and older. Selumetinib is a kinase inhibitor, and it functions by blocking a key enzyme to stop the tumor cells. And we're getting ready to start this little girl on that to see if that could help. Her main complaint is that she can't wear her protective glasses because this orbital tumor is bulging out so much that it prevents her from wearing her glasses. It's really important to have a multidisciplinary team involved in NF kids because these kids can have significant neurologic and orthopedic issues in addition to their dermatologic and ophthalmology issues. And about 50% of these kids have learning disabilities. I'll mention NF2 just very briefly because it usually has more subtle skin findings. It's associated typically with bilateral vestibular schwannomas, and eye findings include cataracts, retinal hamartomas, and distinct flame-shaped epiretinal membranes. Tuberous sclerosis is a much less common autosomal dominant neurocutaneous disorder. These patients can develop hamartomas in nearly any organ system, most often the skin, retina, brain, kidney, heart, and lung. The skin findings include angiofibromas, which appear between age 3 and 5, primarily on the face, ash leaf spots, the shagreen patches, which are these plaques of abnormal skin that appear on the back, and periungual fibromas. Seizures and CNS tumors are common, so we should be on the lookout for papilledema in these kids. Most cases represent new gene mutations with no family history of the disease, but mutations in at least 2 different genes are known to cause tuberous sclerosis. So this is a little 5-year-old boy who has mild angiofibromas of his forehead, and he has a retinal hamartoma adjacent to the optic nerve. His visual acuity is 20/20 in both eyes. Retinal astrocytic hamartomas are the classic eye finding for tuberous sclerosis. They do not usually affect visual function and often do not need any treatment. Here's some other examples of retinal hamartomas. They occur in 44 to 87% of adult patients, and their appearance varies from smooth, non-calcified lesions to the classic white nodular mulberry tumors to subtle areas of chorioretinal depigmentation. The effect on visual function is dependent on their location as well as the size of the lesion. Ataxia telangiectasia is a rare disorder presenting with progressive neurodegeneration, primarily affecting the cerebellum and thus causing ataxia. There's variable presentations of telangiectasias of the conjunctiva and skin, and they also can have cafe au lait spots. These patients also suffer immunodeficiency and a cancer predisposition and are particularly sensitive to radiation. The ataxia can sometimes be associated with abnormal eye movements and strabismus. Incontinentia pigmentae is also called Bloch-Schulzberger syndrome. It's a genetic ectodermal dysplasia affecting the skin, hair, teeth, microvasculature, and central nervous system. Progressive skin changes start occurring in early infancy and may also be present as birth. It has an unusual inheritance pattern of X-linked dominance with a presumed lethal effect on the homozygous male fetus. And nearly all affected people are female with mother-to-daughter transmission in familial cases. Ocular involvement occurs in at least a quarter to a third of these cases, typically in the form of a proliferative retinal vasculopathy that looks a lot like retinopathy of prematurity. At birth, there may be just incomplete peripheral retinal vascularization. And as the retina matures, abnormal blood vessels can occur, as well as neovascular membranes, which can cause vitreous hemorrhages, as well as tractional retinal detachments. Other abnormalities include microphthalmos, cataract, glaucoma, optic atrophy, strabismus, and nystagmus. And these may represent secondary consequences of end-stage retinopathy. As you know, Sturge-Weber is a neurocutaneous disorder with capillary malformations that involve the leptomeninges and the skin of the face. The classic triad of Sturge-Weber syndrome includes ocular abnormalities, especially glaucoma, which can occur in up to 70% of Sturge-Weber patients. A port wine stain is a well-delineated red macule that is present at birth and gets darker and thicker with age. The port wine stain on the left side of the face of this child is associated with ophthalmos, which is typical of infantile glaucoma. In addition, many small and large dark nodules can grow on the surface, resembling pyogenic granulomas. Abnormal capillaries in the brain can impair blood flow and are associated with stroke, seizures, and migraines. This MRI shows the right hemispheric volume loss associated with a prominent leptomeningeal enhancement. It's important to note that not every capillary malformation in a baby is a port wine stain, and it's common for babies to have these feathery pink birthmarks on their forehead, eyelids, and nose. They're often called angel kisses or stork bites. These fade with time and are not associated with neurologic or eye problems. The classic teaching was that the glaucoma in Sturge-Weber is associated with port wine stains in the V1 distribution, but that's not quite correct. The best predictor of adverse outcomes in this large study was having a port wine stain involving any part of the forehead, shown in gray in that diagram, delineated at its inferior border by the line joining the outer canthus of the eye to the top of the ear and including the upper eyelid. This involves all three divisions of the trigeminal nerve, but corresponds well to the embryonic vascular development of the face. So in this study, they showed that if you had this port wine stain in this area, that you had, all of those people had glaucoma. So in this study, poor outcomes in general were associated with port wine stains of the forehead. The port wine stain on the left side of the face of this child is associated with ophthalmos, typical of infantile glaucoma. Recall that tearing, photophobia, and corneal edema are also indicators of infantile glaucoma. There are several theories of the pathogenesis of glaucoma and Sturge-Weber syndrome. There's a mechanical mechanism related to congenital malformations of the anterior chamber angle. It could be due to increase in episcleral venous pressure due to AV shunts into the episcleral hemangiomas. There may be fluid hypersecretion by either the ciliary body or choroidal hemangiomas, or abnormal hemodynamics of the episclera and anterior chamber angle due to premature aging of the trabecular meshwork Schlemm's canal complex. In addition to glaucoma, sometimes we see dilation of the episcleral venous plexus and conjunctival vessels. Choroidal hemangiomas may also be seen, creating this so-called tomato ketchup appearance of the fundus with obscuration of the choroidal details, as seen in the right eye of this patient. Capillary hemangiomas are the most common benign orbital tumor in kids, and we had such a nice overview and presentation of this by Dr. Chen, so I won't spend too much time on this. They're usually not present at birth, but show up by age 6 months and undergo a rapid growth phase. And this is a child who had nothing on as a newborn, and then at 6 weeks of age had this hemangioma, sort of a deep hemangioma nasally on the left eye. She was treated with propranolol, and at age 6 months, The left eye looked good. Note she does have very mild ptosis that's unrelated of her right eye. Patients may have multiple hemangiomas, and it's worth asking about difficulty with feeding or breathing in case there's airway hemangiomas in infants. Treatment includes beta blockers, steroids, laser, and surgery. Facey syndrome is a neurocutaneous syndrome that affects 2 to 3% of all patients with capillary hemangiomas of the head and neck. And these are associated with malformations of the brain, heart, and major arteries and eyes. And again, we had a little review of that, and I'm going to talk a little bit more about that in my next talk. So I'm not going to spend too much time on this. So oculocutaneous albinism, I'm sure we've all seen patients with this. It's a common hypopigmentation disorder that also affects the eyes. This is a group of autosomal recessive disorders that affect melanin production. The lack of pigmentation in the skin is associated with a lack of pigmentation in the iris, which leads to diffuse transillumination defects. This and the lack of choroidal pigmentation cause photophobia in these patients. In oculocutaneous albinism, the optic nerve tends to be small and grayish, and the choroidal vasculature is prominently seen. Patients have foveal hypoplasia, which can be seen clinically and is also demonstrated in this OCT image. Foveal hypoplasia causes poor vision in these patients and nystagmus, and the nystagmus can lead to abnormal head postures, such as this head tilt seen in this little girl. Strabismus is common in these children, and children often require strabismus and or nystagmus surgery. Keep in mind that OCA patients often have large refractive errors and can benefit from glasses, sometimes with tint for the photophobia. This is a complex disorder, and genetic evaluation is recommended. Moving away from something with too little pigment, let's talk about a disorder that has too much pigment. In oculodermal melanocytosis, there's hamartomas of the spindle-shaped melanocytes in the skin, eyes, and central nervous system. It typically presents at birth, but it also can appear in puberty or during pregnancy and is much more common in females. We can see pigmentation of the skin and sclera, as well as iris heterochromia, with the darker iris on the side with the pigment, or diffuse choroidal pigmentation. Patients have about a 10% chance of glaucoma and possibly an increased risk of choroidal melanoma, which is actually quite unusual and occurs in less than 4% of patients with oculodermal melanocytosis. Whites are the least likely race to develop nevus of Oda, but they are most likely to develop malignant melanoma associated with this condition. Patients who have a nevus of Oda who do develop choroidal melanomas have double the risk for melanoma related metastases compared with patients with melanoma arising in an eye without melanocytosis. So we really need to worry about, white patients with nevus of Oda are the most likely to get melanomas, and patients who have melanomas are much more likely to have metastases. Patients should have annual screening for glaucoma and melanoma. There are cosmetic treatments available, especially laser for skin pigmentation, but at this time, there's no good treatments for the scleral pigmentation. Juvenile xanthogranuloma typically causes benign asymptomatic skin lesions that resolve spontaneously. These bumps typically appear on the head, neck, and trunk. Lesions can occur at any age, but are most common in infants and children. Rarely, lesions occur at non-cutaneous sites and can result in serious complications, such as JXG lesions on the iris, which can bleed, causing spontaneous hyphema, or they can interfere with the outflow of fluid, causing glaucoma, or they can block the vision if very large. Sometimes the diagnosis is not obvious with an iris lesion and necessitate excisional biopsies. Rarely, JXG can present as conjunctival lesions, as shown in these examples. They may resolve on their own or may be removed surgically. Scleroderma is a rare autoimmune disease that can either be localized or systemic. In children, it is often localized and does not affect internal organs. Excess collagen produces hard, shiny patches of skin. The terminology is a bit confusing, and dermatologists often refer to localized scleroderma as morphia. There are 5 different types of morphia, but linear morphia is the most common type of morphia in children. Long plaques appear in lines across the body or traveling in the same direction as the arms and legs. If the face or scalp are affected, the condition is known as en coupe de sabre because it looks like the person has been struck by a sword. En coupe de sabre appears as an indented vertical colorless line of skin on the forehead, and you can see that in example D and H in this diagram. In a large multi-center survey study of 750 morphia patients, 3% had eye findings, often occurring early in disease and often in association with other systemic problems. Eye findings were most common in the Coupe de Sabre group, in which 14% had eye findings, mostly of the eyelids, eyelashes, or lacrimal glands. Asymptomatic anterior uveitis was present in almost 1/3 of patients with eye findings. Other eye abnormalities were usually in the context of associated neurologic problems. Because of the relatively high incidence of asymptomatic uveitis, frequent screening is recommended for the first few years of life after the diagnosis of juvenile localized scleroderma. Because of the frequent association of eye with extracutaneous and especially CNS findings, eye findings should prompt further imaging investigation. This patient has linear scleroderma in association with strabismus. She has the Coupe de Sabre version, where it looks like she has an indentation of her forehead, and the right eye is exotropic with poor adduction and poor elevation. This is secondary to involvement of the orbital tissues and extraocular muscles, as seen on her T2 weighted MRI. Let's move on to things that are really common and that we will see very frequently in clinics. Atopic dermatitis is the most common form of eczema. Atopic dermatitis occurs in approximately 10 to 20% of children and 2% of adults. Children with concurrent asthma or hay fever have a 30 to 50% incidence of developing atopic dermatitis. It can present at any age, but often begins in babies at age 2 to 6 months. Most patients have symptoms prior to age 5. Babies tend to have involvement mainly of their face and extensor extremities. From toddlers to teens, involvement is mostly of the cheeks and flexural extremities. And in adults, involvement continues in the flexures and also the hands. Most patients have marked improvement of their skin symptoms during their teens, but about 1/4 of patients will continue to have significant symptoms of atopic dermatitis into adulthood. As many as 40% of atopic dermatitis patients have ocular involvement, and almost all patients with atopic keratoconjunctivitis have associated atopic skin disease. Usually, we think of atopic keratoconjunctivitis as more a disease of adults, but it can also occur in children and can be difficult to distinguish from other problems, especially vernal keratoconjunctivitis. Clinically, we see involvement of the lids and ocular surface. The conjunctiva can develop giant papillae, best seen when eversion of the upper lid. We can also see conjunctival congestion and hyperplasia at the limbus superiorly. Shield ulcers of the cornea are one of the most visually significant complications. They're often sterile, but can become overinfected and can also cause scarring with permanent vision loss. Patients with atopic eye disease are at increased risk for keratoconus, herpetic disease, both HSV and zoster, cataract, which possibly could be related to steroid use, retinal detachment, and treatment-related disease, including side effects from steroids and dupilumab. A recent large study of pediatric atopic dermatitis showed no increase in the rate of cataract development in these children, but there was an increased rate in cataract surgery in these kids. And many of these patients are on topical and systemic steroids, both of which cause cataracts. It's unclear how much is the atopy versus the steroids, which are to blame for the cataracts. When we think about treating atopic keratoconjunctivitis, we think about the mainstays of sort of allergy treatment, including antihistamines, mast cell stabilizers. Of course, many of these patients are on steroids, tacrolimus and cyclosporin A. In the US, there's not a commercially available ophthalmic form of tacrolimus, but you can use the dermatologic preparation in the eye, and it works quite well. Dupilumab, which the trade name is Dupixent, is approved for treatment of moderate to severe atopic dermatitis in children ages 6 and up. It's a human monoclonal antibody that inhibits the binding of key interleukins involved in the pathogenesis of atopic dermatitis, and it's been shown to provide significant relief of symptoms for patients. In several clinical trials of this drug for atopic dermatitis, there's been higher rates of conjunctivitis in the drug group than in the controls. In this study of patients referred to ophthalmology for conjunctivitis that were on dupilumab, there were 2 clinical patterns of ocular surface disease. Most patients had mild, nonspecific conjunctivitis with dry eyes, which improved with conservative measures like warm compresses and artificial tears without any recurrence. Rarely, patients developed a severe dupilumab-induced follicular conjunctivitis without keratitis, which required specific ophthalmologic management, including steroids. When patients were seen and managed by ophthalmology prior to starting drug treatment, the proportion developing conjunctivitis on the drug treatment dropped from 25% to about 12%. About a quarter of patients on dupilumab developed conjunctivitis in the first 6 months of treatment. When the patients were seen by ophthalmology prior to initiation of treatment with dupilumab, a large number were found to have pre-existing ocular surface disease. And when this was managed preemptively, the number that developed conjunctivitis dropped significantly. So the takeaway point is that many atopic dermatitis patients probably already have ocular surface disease and benefit from ophthalmology evaluation and treatment prior to initiating therapy. Rosacea is another common dermatologic disorder, which is most typically seen in middle-aged women. It can occur in kids, and in children, ocular symptoms often precede skin findings. Rosacea is characterized by flushing, erythema, telangiectasias, papules, and pustules on the central face. Often there's associated lid margin disease, including blepharitis and meibomian gland dysfunction. Most of the treatment of pediatric rosacea is based on adult studies or on just small case reports. Treatment of rosacea includes lifestyle modifications, including avoiding triggering agents such as spicy foods and sun exposures. There are many topical treatments for rosacea, skin treatments, which may work or might increase irritation, and these are usually managed by a dermatologist. Systemic treatment with long-term antibiotics is often needed. In children, rosacea skin disease is relatively rare, and ocular rosacea frequently accompanies skin findings or even precedes the skin findings, so it is likely that pediatric ocular rosacea is underdiagnosed. There's no widely accepted diagnostic criteria, but this is one proposed criteria for ocular rosacea that emphasizes chronic or recurring keratoconjunctivitis, blepharitis, and meibomian gland dysfunction, eyelid telangiectasias, skin findings, and a family history of rosacea. 3 or more of these criteria suggest ocular rosacea. It's important to diagnose ocular rosacea as children may present with more severe ocular disease, including corneal vascularization and scarring that can reduce vision. Children with rosacea have a high incidence of severe disease. So in this small case series, chalazions and blepharoconjunctivitis and meibomian gland dysfunction were all very common, but also keratitis and corneal ulcers were present on presentation in a number of children. And these are especially important because they can cause permanent vision loss due to both scarring and/or amblyopia. Often kids with ocular rosacea develop skin findings and have problems well into adulthood. Lid margin disease can be treated with the usual conservative measures of warm compresses, lid scrubs, increasing omega-3 fatty acids, and artificial tears. Topical antibiotics, especially azithromycin, can be helpful as the macrolides have anti-inflammatory effects as well as their antibiotic effects. Systemic antibiotics include the tetracyclines and the macrolides, such as erythromycin, azithromycin, clarithromycin, all have anti-inflammatory effects. The antibiotics will need to be used for long periods of time in ocular rosacea, so it's important to consider side effects. First generation tetracyclines can stain the teeth and cause bone problems and should not be used in children under 8. Second generation tetracyclines like doxycycline are safer for the teeth and bones and be cautiously used in younger children. All tetracyclines, including doxycycline, can cause photosensitivity. Newer macrolides, such as clarithromycin and azithromycin, tend to be well tolerated in kids with less GI symptoms and less potential drug interactions than erythromycin. We've been discussing lots of skin diseases that are associated with lid margin disease and keratoconjunctivitis, and certainly there's a lot of blepharitis in children, particularly in kids with Down syndrome, but really all kids. For many kids, an overgrowth of Staphylococcus or seborrhea may be to blame for the blepharitis. But I wanted to show you something else. Twice in my career, I've seen this while examining a patient with blepharitis. And you notice that the lashes seem to be waving at you under the slit lamp. This is pubic lice. You can see the nits and the lice in the lashes. It's important to note that head lice do not like eyelashes, but pubic lice do. And if we see this in children, it raises the suspicion of sexual abuse. So with that, I appreciate your attention. I would highly recommend befriending a dermatologist to help you with these challenging patients. There's a lot that we can learn from dermatology and them from us. Thank you so much. I can take questions now, or we can go on to the next and I can take them at the end.
Thanks, Laura. Why don't we take all the questions together? So we give you enough time to give your talk.
Okay, I'm going to go ahead and get the other one up. The Zoom thing is hiding my toolbar for my PowerPoint. Sorry. Okay. I'm going to discuss 3 unusual pediatric eye disorders that are associated with cardiovascular disorders. These are things that can kill kids if they're not properly diagnosed. And if you make the diagnosis, you can potentially save the child's life. These are truly disorders you don't want to miss. So we've already talked a little bit about phases. This is a 2-month-old little boy with a rapidly growing capillary hemangioma. He's obviously at high risk for deprivational amblyopia, but what about other problems? And as we've already seen a couple times today, because of the segmental pattern of the hemangioma, this child is at risk for the neurocutaneous syndrome phases. Phases syndrome is an association between infantile hemangiomas at the head and neck and malformations of the brain, heart, and major arteries in the eyes. Phase syndrome occurs in 2 to 3% of all infantile hemangioma cases and probably involves a disruption between 3 and 12 weeks of gestation. PHACES is an acronym for the findings in this disorder. P is for posterior fossa brain malformation. Structural abnormalities of the brain include Dandy-Walker syndrome and hypoplasia of the cerebellum. The hemangiomas in PHACES syndrome tend to be large, greater than 5 centimeters, or segmental, involving the head and neck. The majority of phases patients have involvement of the supratemporal region, or region 1 in this diagram. And these are ones that are likely to be seen by ophthalmologists because they involve the lid. Those in the frontal segments 1 and 4 are also likely to have brain and eye involvement. Note that the hemangioma of this child in region 2 is relatively mild compared to the last example I showed you. It is still large and segmental, and this child has phases, so don't discount a faint hemangioma. Hemangiomas in the mandibular segment 3 tend to have more respiratory and midline problems, including cardiac issues. Children with mandibular hemangiomas can be at increased risk of respiratory and cardiovascular issues with surgery. So beware if you need to take these children for strabismus surgery or nasolacrimal duct probing. Cerebral vascular arterial anomalies are the most common extracutaneous manifestation of phases and are associated with strokes. Coarctation of the aorta is the most common cardiac anomaly and can be life-threatening. Eye abnormalities occur in phases but are relatively rare. Posterior abnormalities are more common and include morning glory disc anomaly, optic nerve hypoplasia, and persistent fetal vasculature. Many other ocular anomalies have been reported, including colobomas, staphyloma, sclerocornea, microphthalmia, and cataract. If an eye anomaly is seen in association with an infantile hemangioma, think about this syndrome. Midline sternal and ventral defects are associated with phases. This is something easy to check in the patients referred for infantile hemangiomas. If a child with an infantile hemangioma has a midline defect, then you should also think about phases syndrome. All large and or segmental facial hemangiomas should also be evaluated. Workup includes MRI, MRA, cardiovascular evaluation, and echocardiography. Let's move on to another interesting case. This is a healthy 11-year-old referred by her optometrist. Her past medical history, family history, and development were all normal. She was tall and thin, as you can see in this image. She had no abnormal joint laxity, and her fingers were normal appearing. Her refraction was moderately myopic with good corrected vision, and her retina was normal. The slit lamp revealed bilateral lens dislocations with phacodenesis and shallowing of the chambers inferiorly. There was no glaucoma. And if we had more time, I would make the residents guess at this diagnosis. My first guess was Marfan syndrome. It was high on my differential because of the lens dislocation and the body habitus. It's an autosomal recessive inherited disorder of connective tissue. The gene that codes for fibrillin is abnormal, and that gene can be tested. Patients tend to be tall and thin with scoliosis, long limbs, and hyperflexible joints. Hand findings can be very suggestive, but not diagnostic of Marfan syndrome. They might have the thumb sign, in which the thumbnail extends beyond the palm when folded in, or the wrist sign, in which the thumb and finger overlap when wrapped around the opposite wrist. Mitral valve prolapse and aortic root dilation are common and can be life-threatening in Marfan syndrome. Eye findings include lens dislocation, axial myopia with increased risk of retinal detachment, and periocular syringomas. So my kid with bilateral lens dislocation was referred to cardiology. Her aorta was normal. She underwent genetic testing for Marfan syndrome, which was also negative. And some time went on, and I saw her a couple more times. And finally, I thought to check her plasma homocysteine levels, which was elevated. And she ended up having homocystinuria. So homocystinuria, or cystathionine beta synthase deficiency, is a diagnosis you don't want to miss. It has many similarities in presentation to Marfan syndrome. Like Marfan syndrome, homocystinuria patients have myopia and lens dislocation. Lens dislocation occurs in 50% of patients by age 10 and 97% of patients by age 40. Homocystinuria has skeletal features similar to Marfan syndrome, and patients often have long limbs, scoliosis, and pectus excavatum. Unlike Marfan syndrome, homocystinuria patients frequently have neurologic issues. These are not universal, and my patient had no neurologic signs or symptoms. The reason you don't want to miss this disorder is because of the associated vascular problems that can kill these patients. There's a high incidence of atherosclerosis and thromboembolism. Both the venous and arterial systems are affected, with both large and small vessels being affected. Patients can suffer from pulmonary embolism and strokes, and bilateral central retinal artery occlusions have been reported. 30% of patients have thromboembolic events by age 20 and 60% by age 40. These disorders have a high morbidity and mortality in young people, and early treatment can sometimes prevent or delay complications. In the US, most but not all newborns are screened for homocystinuria. These screening tests have a high false negative rate for detecting homocystinuria, and physicians cannot assume that newborn screening will detect the disease. Plasma homocysteine levels or genetic testing should be done if there's suspicion of homocystinuria. Patients should be managed by a metabolic expert familiar with the treatment of homocystinuria. About half of all patients will respond to treatment with pyridoxine, vitamin B6, and folic acid. The other half do not respond to pyridoxine and must eat a diet low in protein and methionine. Interestingly, my patient had been vegetarian for a long time by choice. She had just chosen a low protein diet. They may also respond to a drug called betaine to lower their homocysteine levels. Genetic counseling and examination of family members is important. My patient had an older sister who was undiagnosed but had subtle lens dislocation on dilated exam and high homocysteine levels, and she was also diagnosed with homocystinuria. It's important to make the diagnosis early in these seemingly healthy patients in order to reduce risk factors. A quarter of patients die before age 30 from thrombotic events. These patients should not use oral contraceptives or smoke. Patients are at a significant risk of thromboembolism, even with minor surgeries such as lensectomy. Preoperative levels of homocysteine should be reduced to near normal levels. During and after surgery, aggressive hydration and prophylaxis for deep venous thrombosis are also recommended. So suspect homocystinuria if it's not Marfan's with lens dislocation. Check plasma homocysteine levels, check family members. Early diagnosis and treatment can save a life by reducing the risk of thromboembolism. One more quick case. It's a healthy toddler with a left exotropia. She had a binocular fix and follow, but objected to occlusion of the right eye. The external and anterior segment exams were unremarkable. She had an intermittent exotropia at distance with a small exophoria at near and normal versions inductions. The right fundus was normal, and this was the appearance of the left fundus. And this is a morning glory disc anomaly. Morning glory disc anomaly is named because of its resemblance to the morning glory flower. It's a large nerve with pink or orange coloration and peripapillary atrophy or pigmentation. There may be a central glial tuft. There's often a funnel-shaped peripapillary excavation, which can be seen in this OCT image. Retinal folds and serous retinal detachment can occur, and the radial retinal folds sometimes pulsate. The vessels are typically straight, increased in number, and exit the nerve radially. It's difficult to distinguish the arteries from the veins. Patients may develop choroidal neovascular membranes as shown by the arrow. Vision is typically poor in these patients, and they often have a afferent relatory pupillary defect because the anomaly is usually unilateral. Strabismus in infancy, as in my patient, is a common presentation. In a moving toddler, sometimes it's challenging to thoroughly evaluate the optic nerve. So I just want to quickly review some other congenital optic nerve anomalies to help you distinguish the morning glory disc, which is shown here, and make the correct diagnosis. Optic nerve hypoplasia is the most common congenital optic nerve anomaly. In this, the nerve is small, gray, or pale yellow, and the vision is variable. Usually this is bilateral, but it can be very asymmetric. There may be a ring of increased or decreased pigmentation, which gives the classic double ring sign, and the small nerve can be mistaken for the cup of a normal sized nerve. Unlike the straight vessels of morning glory disc, the vessels in optic nerve hypoplasia are often tortuous, and that can be a clue to look at the nerve more carefully. Patients with optic nerve hypoplasia commonly have midline defects, including pituitary problems, other brain abnormalities, and developmental delay. They need MRI and endocrine evaluation. Peripapillary staphyloma is rare, usually unilateral problem, which the nerve is at the bottom of an excavated defect. The optic nerve may be normal or may have temporal pallor. There's no central glial tuft and normal retinal vessels in staphyloma. Finally, there may be confusion with optic disc colobomas, which also make the nerve appear larger than normal. In the coloboma, there's a sharply delimited glistening white bowl-shaped excavation inferiorly and an enlarged disc. The inferior neuroretinal rim is thin or absent, while the superior portion of the nerve is relatively spared. The vessels have a more normal pattern than in morning glory disc anomaly, and the coloboma may extend to involve the choroid and retina. Microphthalmia and iris and/or lens coloboma may also be present. Colobomas are usually colobomas can be unilateral or bilateral equally. The vision can be variable, and this patient actually has normal vision despite the large coloboma. Colobomas can be isolated or part of a systemic disorder. So let's go back to the kid with the morning glory discs, strabismus, and anisometropia. We did all the usual things with polycarbonate glasses for protection and to treat her anisometropia. An attempt at patching was made. It was not surprisingly not successful. The patient underwent an endocrine evaluation and an MRI, which was normal. I also obtained an MRA, which was most definitely not normal. Her MRA showed an absent left internal carotid artery. She's neurologically normal, so how is her left brain getting perfused? Well, recall that the circle of Willis provides collateral circulation in the brain. Vascular anomalies such as this are common in morning glory disc anomalies. In the largest series of 20 patients with morning glory disc, 45% had cerebrovascular anomalies. Vascular abnormalities were typically in the anterior cerebral circulation and ranged from mild narrowing to complete absence of vessels, as in my patient. Moya is much less common than vascular anomalies, and it occurred in only 3 of 20 patients. In Moya, both the intracranial arteries are involved and collaterals form at the base of the brain, which look like a puff of smoke. These changes can be progressive and place patients at high risk for ischemic and hemorrhagic stroke. For patients with vascular anomalies, it's important to modify risk factors and follow for progression. And for patients at high risk, vascular events can be precipitated by dehydration, anesthesia, or even crying that drops down the CO2. This is another patient of mine who is a healthy 8-year-old with morning glory disc anomaly of the right eye. Interestingly, she has cerebral vascular anomalies on the left side, opposite the optic nerve anomaly. She's now on daily aspirin and is followed by neurosurgery with serial MRA monitoring, since many of these patients progress. It's important for patients to know that they're at high risk for stroke and to report to the emergency room with any new neurologic symptoms. In addition to vascular anomalies, morning glory disc anomaly can be associated with transsphenoidal basal encephalocele, which is a herniation of meningeal tissue and sometimes contains the optic chiasm and hypothalamus. These patients can have midline facial abnormalities, including hypertelorism and a cleft lip or cleft palate, and can also have pituitary issues. The encephalocele can even protrude into the mouth or nose and cause respiratory issues. So remember, we've already talked about Facey syndrome, which can have eye abnormalities, including morning glory disc anomaly. So in your patient with morning glory disc, make sure that you're not missing subtle hemangiomas or sternal defects. And in a patient with Facey's, check for morning glory disc anomaly. In summary, it's important to distinguish morning glory disc from other congenital optic nerve anomalies because the associations are different. MRI and MRA is best for screening patients to identify basal encephalocele, other midline defects, and especially intracerebral vascular anomalies. Patients may need endocrine evaluation and be on the lookout for hemangiomas or other signs of Facey syndrome. Vascular anomalies are common even in older asymptomatic patients, and making the diagnosis is important so that patients can modify risk factors such as smoking and oral contraceptives. So don't miss these conditions. They can have serious cardiovascular consequences. Facey syndrome can have with infantile hemangiomas and cardiovascular abnormalities, homocystinuria with lens dislocation and a high risk of thromboembolism, and a morning glory disc anomaly with cerebral vascular defects. Thank you. I'm happy to take any questions or any comments. I'm sure Dr. Levin has lots of experience with all these rare disorders. And Matt probably has some things to add too.
A great talk, both very good and very informative.
Thank you. I hope the residents found all the phacomatoses particularly interesting with OCAPs around the corner.
So I'm going to show you a great little trick. Can you put
Sure.
your slides back up for a second, the second lecture?
Sure.
Is Randy on the call here somewhere? Out there, Randy? Go to your homocystinuria. The picture right after her.
Sorry, let's see. So here's my little girl.
Right there, go right there.
Go back more to
Go
the
back there, so you can do it here. If you blow up that slide, you go to that picture there with her. There you go. If you look real closely, do you see, Randy, I don't know if you're out there, but we talked about this in clinic yesterday. You see how there's these little tiny, the lens edge has little tiny crenulations all the way around. It's not flat like you see in Marfan's. It's got those little divots all the way around.
I see
That's
that.
homocystinuria. That's because the zonules break in homocystinuria, but they stretch in Marfan's. So when you see that, it's almost always going to, there's a few others, but almost always going to be homocystinuria. So that's a neat little sign that is easy to miss.
That's a great pearl. What do you make of the whole direction of the lens dislocation? I've seen lenses go different directions, but
that's correct. And although if you ask the question, the percentage of downward going lenses is higher in homocystinuria, and the percentage of higher upgoing lenses is higher in Marfan's, it can go any way in any condition.
The thing.
Yep, go ahead.
I'm sorry, I didn't mean to interrupt you. I was just going to say, before I met this patient, I had always thought of homocystinuria as having serious neurologic problems. And so I have now diagnosed 3 teens that seemed relatively normal with homocystinuria, and one of them was chubby. So
yeah, 50% of them have normal mentation. The other 50% can have anything that ranges from little school learning problems to behavioral problems to severe developmental delay. But that sign, you can see it, the edges is really characteristic.
That's super helpful. Thank you for telling me that. And I will add that to my slide for the next time I present it. That's great, Pearl.
That was a fun talk.
Thank you.
Laura, with those the sublux patients, if you're operating for them, what do you do for optical rehabilitation?
Contact lens all the way. Yeah, I have sutured a couple IOLs in, and after 10 years later being on the patient's retina, I decided I'm never going to do that again. And, you know, she's an older child, fine with contact lens. I even have a couple Marfan's patients where the lens is just dislocated enough, it's out of the way, and they wear an aphakic contact lens and their lens hangs out and doesn't cause any problems, and we leave it alone.
Yeah, I think my first couple years in practice, I was suturing a lot of lenses in these kids. And then Ed Buckley gave his talk at APOS one year, and I think Alex came to give rounds in Rochester when he was still in Toronto and said, they're going to fall. And I was like, they're not going to fall. And within a year or two, they start all falling. And so, yeah, I'm doing contact lenses now.
So what do you do now, Matt?
I just leave Mayfake and put a contact lens on. Yeah.
I
David's
would argue with the new Gore-Tex sutures that falling lenses will be much less in the future. Now it's a short,
Well, the
it's a
problem
short
is not
interval.
the problem.
Sorry?
I was saying the problem is not the suture. The problem is the sclera of the child. And there's something about the sclera of a kid. It's soft and pliable that it just, people have tried every suture imaginable and they just seem to fall in kids.
I'm not sure about that. I mean, it depends on how you're suturing it. I mean, if we're talking
That may
using the
be
old 10-0
impressive.
nylon, it was a very focal type of suture. There's a very broad sling that we're using now with the Gore-Tex, which I think would get around that pliable sclera.
I guess it depends
I
on
think
how
the
long
artisan
future
lens
we're
will have a
talking
role as
too.
well.
I'm sorry?
I said, I think it depends how long future we're talking too. You know, these kids need 50, 70
Oh, absolutely.
years.
No, I mean, I do a number of scleral-fixated lenses. Mostly they're young adults I see with Marfan's that I'm doing. And, with the new techniques that we've been doing in the last few years, just a much different technique than it used to be.
One thing I would say too, sometimes it can be super challenging when the lens is partially dislocated and you're trying to decide what to do. Sometimes I've found that dilating the pupil and putting an aphakic lens is a great way to see how they're going to do with that and can buy you some time, particularly if the patient's not medically stable.
And you want to be careful with the Marfan kids as well. There's often associated retinal findings, and you can go in there, things look great, and all of a sudden the retina starts detaching. So, yeah, I'm not arguing against being conservative, but I'm just commenting about the new techniques and the new sutures. It can be
They
much,
have a
much better.
20% retinal detachment. There's a great paper that was written that compared the rate of retinal detachment today versus like 30 years ago with, better instrumentation and all that, still 20% retinal detachment. And that's because it's the fibrillin gene that causes the problem. You need fibrillin to keep your retina on.
Yeah, I mean, we'll often, if we go in there, and even if it looks good, we'll often do this prophylactic 360 laser. Laura, that was a great comprehensive talk. I'm blown away. You guys really have to be comprehensive ophthalmologist, dermatologist, neurologist. It's really great to see that. And so we appreciate you sharing our knowledge with us. I don't know if everybody can see this. This is, normally I'd be shaking your hand and handing this to you, but we'll be sending this to you in the mail to add to your collection of awards to hang on your wall in your office. And we really, to commemorate your visiting professorship here. So thanks again for attending. Really appreciate it.
Well, I am so honored to be here and so delighted to learn from all of you, of course, from Dr. Geringer and Dr. Levin, but also your really outstanding and impressive residents who did a fantastic job today. I wish I could be there in person.